I'd like to thank the organizing committee, the head of the department, Rheumatology and Rehabilitation at Asyut University, and Professor Nihal Fathi, who invited me to be with you here today to speak to you about osteoporosis update and fracture liaison service. There is nothing to disclose in relation to this presentation. The clue to the recent developments in osteoporosis started by the NORA study, which was published in 2002. The study was carried out to assess or evaluate prediction of fracture risk in postmenopausal white women. The study included over 200,000 postmenopausal women. However, it was very interesting to find that more than half, 52% of the NORA women who experienced osteoporotic fractures had BMD in the osteopenia range between -1 to -2.5. And assessing the prediction for risk, those with osteoporosis as assessed by T-score were 2.74% times higher than control group with normal BMD independent of the demographic and clinical risk factors, whereas women with osteopenia had 1.7 times higher risk of fracture. So osteopenia, which in the past we were considering as a transient state and does not require any treatment, it is by itself makes a patient prone to sustain a fracture. And actually the outcome of that study highlighted the unmet need to identify those patients who are most likely to sustain a fracture and who are really in need to targeted pharmacological intervention to prevent these fractures. Reflection of what we have so far, trabecular bone loss and vertebral fractures are, by history, are the hallmarks of osteoporosis. However, if we look at the fractures that happen in the patient body, fragility fractures, 80% of the skeleton is cortical. 80% of all the fractures are non-vertebral. 30% are distal forearm. So the T-score concept, which was developed to assess the probability of fragility fracture in postmenopausal women, was mainly designed for those in mid to late 60s years old and older. This has been useful because in this age group, the disease prevalence, osteoporosis, is high. However, there are challenges to T-score. T-score has its own problems if I used it outside this range, the mid-60s and older. Practitioners have assumed that all patients with abnormal low scores have primary osteoporosis. But the T-score itself as a number is insufficient to accurately make such diagnosis in patients outside the demographic group, younger than mid-60s, simply because the disease prevalence in younger women makes the score less accurate as a predictive tool. Also, the T-score is associated with issues like we have, I believe all of us, we've seen that, different T-scores at different sites. You can have a different T-score at the lumbar spine, different from that at the hip, different from distal forearm. Which T-score shall we rely on? We, as a solution, we say take the lowest T-score. The second challenge is that there's a big distance between -1 and -2.5. And the fracture is actually not linked to the T-score, it's linked to the bone mass. And the fracture, the bone mass loss is a continuum, it's going on. And therefore, the fracture risk is also a continuum. This takes us to the relative and absolute fracture risk. The ratio of risk of those relative risk is that ratio of those who are exposed to a condition, like for example, specific T-score, compared to those who are not exposed to that one. And we all know that for every standard deviation loss, the bone mass, there is relative risk of fracture. There is doubling of the relative risk of fracture. So what is absolute fracture risk? This is the combination of bone density and risk factors combined together to assess the absolute fracture risk. In younger women, the relative risk is quite low because these are young, and it remains low even if it doubled. Let me give you this example. absolute fracture risk of a 50 years old lady with a T-score of -3, which is a score all of us will say, oh, wow, that's considerable osteoporosis. The fracture risk, absolute fracture risk here is exactly the same as the absolute fracture risk of 80 years old woman with a T-score of -1, which is a score if we saw, we'll say, oh, that's excellent, it is normal. So the T-score by itself is not everything. It is just a part of the story. And BMD measurement is used to reflect the bone remodeling continuum and degree of bone loss. So also BMD assessment is one component of the bone strength. So this forced us to change the concept from BMD centric, where we used to do, rely on BMD assessment, identify T-score, give treatment, into what we call fracture centric. Let me share with you this one. This is a gradient of risk with the use of bone mineral density at the femoral neck versus clinical risk factors versus combination. So these are hip fractures and different age group, 50, 60, 70, 80, 90. And assessment of the fracture risk based on the BMD, 3.68. If I assess chronic risk factors only, 2.05. Both together, 4.23. So when I combine the chronic risk factors, clinical risk factors, in addition to the BMD, I have better understanding and better estimation of absolute fracture risk. This is applicable also to all other fracture risk sites apart from the hip, but we consider the hip as it is the most serious and the most important one. So by combining clinical risk factors, in addition to the BMD, it gives me a better picture. FRAX is the most commonly used one to assess absolute fracture risk, and I'm included this in my study to congratulate Saudi Arabia, as they have just launched their FRAX adapted to Saudi people last October. Okay, so we got fracture risk assessment, absolute fracture risk. How can we identify the patients? In UK, we started with NOG and split the patient into 3 groups. Either low risk, which is green, and these need only calcium and vitamin D supplementation, advice regarding lifestyle and nothing more. In the yellow here, these people require BMD assessment, and in the red, this is the people to treat. Recently, the United States published its cutoff points. I know it is there for quite some time, but I'll show you what's recent now, where we have the low risk, 10-year probability of major hip fracture less than 1%, major osteoporosis fracture less than 10%, moderate risk, 10-year probability of hip fracture less than 3%, and major osteoporosis fracture less than 20, high risk hip fracture more than 3, major osteoporosis fracture more than 20, and very high risk, where the FRAX score was more than 30 for major osteoporosis fracture and more than 4.6 for hip fracture. This actually mandated similar change in how the UK assess the patients. So now we have the low risk, and in this yellow area, after assessment of BMD, I can have either low risk, which is treated like low risk area, or high risk, and they deserve treatment, and versus those in the red area where they are at high fracture risk, this equivalent to high fracture risk in the US pattern, and require urgent management. 2 years ago, we had a recent item introduced into the osteoporosis field, which is the imminent fracture risk, meaning that any patient who has a low trauma fracture is at high risk of sustaining another fracture within 24 months of the primary fracture. As we can see here, there's the high risk. Then after 2 years, although it gets low, but gradually goes up again over 10 years. However, the highest risk is in the first 24 months. And this is the window of opportunity for us to treat as soon as possible so that we prevent another osteoporotic fracture. This study actually is excellent. It was done in Canada, Ontario, And it shows the median time to second fragility fracture occurring at any site. And they put here the number of index fracture, like for example, hip here, 31,000, and the number of proportion of a second fracture, 5,000, and the time taken for it. And as we can see here, nearly high percentage, 15.9 up to nearly 19 and 20% of the patients develop another fracture within 1 to 2 years of the primary fracture. Very interesting study showed patients who had a low trauma fracture or fragility fracture, how many of them percentage have had DEXA scan before the fracture and how many of them had DEXA scan after the fracture. And as we can see here, before the fracture is between 5 to 10% for all patients, here about 14.7. After fracture, which is a surprise, it goes maximum up to 26 or 27%. So nearly 3/4 of the patients do not even have fracture assessment risk after the primary fragility fracture, which represents a treatment gap. This is a study done in Saudi Arabia, which is very interesting. Characteristics and outcome of osteoporotic hip fractures. They included 264 patients, half men, half women. And after the fracture, majority underwent surgery, 92%, surgical complication, 5.7%, medical complication, 7.9%. Vitamin D and calcium were the most common medication, but given only to 17%. BMD significantly more after the fracture. However, very few patients received osteoporosis-specific therapy. With follow-up revealed that 23% of the patient died after 1 year of surgery. So this shows us more than one factor. It's actually the average between about 25% of the patient die in the first year, 25 of them die in the second year. Number two, again, the same figures as we've seen in Canada. Very small number of patients had DEXA scan after the fracture. Imagine how many of them had DEXA scan before the fracture. Another study done in Saudi about estimated direct medical cost of osteoporosis, and I wish we can have similar studies in Egypt. So for patient with osteoporosis, the direct medical cost for patient without fracture but have osteoporosis is $975. After fracture, this jumps up to $99,716, and this 9,000 figure is attributed to the surgery. This shows you how important it is to assess these people as economy is suffering and paying for, at least in Egypt, the patients are paying for the consequences of the fracture. I'm pleased to share with you the good news that early this year, we published the first consensus on treat-to-target approach for osteoporosis. This was published this year. And this is an algorithm, which was the algorithm for osteoporosis management in Egypt was again fracture-centric, including BMD and giving guidelines toward the full management of osteoporosis, including osteoporosis gap, treatment gap. As we all know, we assess for fracture risk, and however, FRAX does not include assessment for falls. And therefore, we introduced this combination of falls risk assessment as well as FRAX risk assessment to be completed by the patient while he's sitting in the waiting area. This will enable you to assess his absolute fracture risk. And here, if you tick whatever boxes, these are the factors, the weight of everyone, and these are the cut-off points. This form has been introduced by the Egyptian Academy of Bone Health and Metabolic Bone Disease. In view of this, the International Osteoporosis Foundation has launched its service for Capture the Fracture, meaning that make the first fracture the last one. Not only the IOF, Royal College of Physicians also has released some information for patients, and I'd like you to see this advert released by Royal College of Physicians.
Broken a bone? Post-fracture care coordination programs, such as fracture liaison services, can make a difference to your future. 30% of adults aged 65 and over fall annually. If that person has weak bones due to osteoporosis, even a small slip on the pavement can result in a broken bone. At the hospital, doctors will repair the broken bone, known as a fracture. All too often, the patient is simply sent home without further investigation of why the fracture happened. But did you know that if you've broken a bone, you are at double the risk of breaking another within a year? Fractures can have devastating consequences, causing pain and loss of mobility, and even loss of independence. That's why, if you've had a fracture after the age of 50, you should have your bones checked. With the right treatment and follow-up care, future fractures can be prevented. Many hospitals provide post-fracture care programs, such as fracture liaison services, known as FLS, to ensure no patient goes home without good post-fracture care. In an FLS, a team of healthcare professionals works together to ensure all fractured patients are identified, diagnosed, and treated for osteoporosis. Patients will also receive falls risk assessment and proper follow-up care. With the right post-fracture care, future fractures can be avoided and independence maintained. Remember, after a fracture, make sure you get a bone health checkup. Ask whether your hospital offers a fracture liaison service. Visit www.capturethefracture.org to learn more.
And I'm pleased to say that in Egypt now we have 13 FLS fracture liaison service centers. One, I'm pleased to say that Asyut is represented, and this star here represents Asyut. We have Asyut and Sohag and Aswan in Upper Egypt providing this service, and the rest are in the north of the country. And definitely you can approach our team and Professor Nihal Fathi in Asyut, who can guide you with the services provided by the FLS service. So when we look at the structure of FLS service, we can see that there is a lead who is involved with designing the local FLS model of care, FLS coordinator with case finding, this is responsible for case finding and patient assessment, integrated care pathway, which is a challenge to us in general Egypt, because we should agree with other specialties dealing with patient fractures, like, for example, orthopedics, radiology, or orthogeriatrics. And lastly, quality improvement is important. Like, for example, doing an audit to confirm that the fragility fracture sufferers receive appropriate assessment and long-term care. Okay, so how can we assess this? First, as we've seen, it's important that the patient should be aware of what are their risk of developing another fracture, and if the patient has been seen in an FLS service, what are the services should be provided to him. So the patient should be seen within 12 weeks by the FLS, and during which time they should have a DEXA scan. By 16 weeks, the patient should have started 3 treatments and at least discuss rehabilitation program with him. By 32 weeks, the rehabilitation program should be running or completed, and 52 weeks to check whether the patient continue to take their medication or not. By 2 years to have a repeat DEXA scan, and 3 to 5 years to have a discussion regarding drug holiday. So this is a chart, the patient-friendly format to help the patient, guide the patient regarding what they expect and how to manage. The IOF also has launched or has published key performance indicators, and these are not only to assess our service, but also to compare our service to other centers in the country and internationally. So this actually will help us to identify our weak and strong points. The key performance indicators, as we can see here, published by the IOF, is mainly 10 points. In Egypt, we have published our Egyptian recommendation with 19 key performance indicators. And these should help not only to assess for the fracture risk, but also we included sarcopenia assessment, cognitive assessment, as well as rehabilitation program and balance initiation. So in conclusion, the aging demographic poses a major threat to healthcare, with absolute increases in the burden of non-communicable diseases, particularly osteoporosis. Bone mass loss is a continuum, not just a T-score. Patient stratification for bone health should rely mainly on absolute fracture risk assessment. The patient-level key performance index or indicators support FLS to examine their current performance and add service improvement cycles to their routine service provision. It also permits further benchmarking against fracture lesion services regionally, nationally, and internationally. Thank you.
Thanks a lot, Professor Yasser Medani, منور طبعا, for this very informative presentation as usual. طبعا حضرتك موجود معانا ابرود, فهنفتح الدسكشن على طول ان شاء الله. اي سؤال دكتور ياسر يا شباب؟ دكتور احمد اتفضل. دكتور احمد الياسقي حبيبك.
اهلا يا ياسر، ازيك؟ طبعا بصراحه انت منور الشاشه ومنور مصر كلها ومشرف مصر الحقيقه. حبيبي دلوقتي انا ليا سؤال، هو الاف ال اس اللي هو الفراكشر ليزيس سيرفيس، هل في بقى كمبيوترز وداتا بيز للعيانين اللي عندهم فراكشر في جميع انحاء الجمهوريه علشان نعمل لهم بعد كده فولو اب ونمنع بعد كده؟ يعني طبعا هو حضرتك شرحت دلوقتي واحنا عارفين ان وانس اوستيوبروتيك فراكشر اولويز اوستيوبروتيك فراكشر، فعلشان نعمل فولو اب للعيانين دولت ويبقوا اتاتشد لينا ونتابعهم ونمنع ان سكند اوستيوبروزيس يحصل، اوستيوبروزيس فراكشر اسف يعني، فهل في بقى كمبيوتر سيستم وداتا بيز والحاجات دي بحيث يتجنبوا حاجه زي كده؟
بالضبط. ايوه في دكتور احمد طبعا شكرا على المقدمه. ايوه في احنا عملنا داتا بيز على ومعانا تقريبا تخص تقريبا معظم الفراكشر، مش هقول كل، لان كما هو متوقع يعني الاورثوبيديك سيرجري مش متعودين قوي او مش مؤمنين قوي بحكايه الاورثوبيديك فراكشرز، هم غالبا عايزين فراكشرز عشان
يشتغل.
لكن احنا فعلا عندنا داتا بيز وشغالين بيها في معظم المحافظات، بتدخل الداتا ودي شركه بتدخل الداتا.
تمام، وهم كومبلاينت، الاورثوبيديك سيرجن والراديولوجيست كمان كومبلاينت معانا. بتحاول
كل حته بقى بتشوف الضغط بتاعها، في حتت صعبه في حتت سهله، بتبقى متوقفه على السيت اب بتاعت الجامعه دي او المستشفى.
تمام.
الراديولوجي لحد ما كويس. طبعا ده نقطه مهمه قوي حكايه الراديولوجي دي علشان السايلنت فيرتيبرال فراكشرز.
ايوه.
ناس كتيره بتفوت عليها وبتطلع بالصدفه في الاكس راي، فالراديولوجي مهمين زي الاورثوبيديك سيرجري بالظبط.
تمام.
لكن ايوه كلامك مهم، لان من غير الداتا بيز دي احنا مش هنعمل حاجه.
ايوه.
هو عيان وممكن يقع منك في
اكيد
3 مانثs و 6 مانثs اوف مانجمنت.
بالظبط، يعني محتاج يعني مالتي ديسيبلينري ابروتش عشان خاطر نوصل للعيان ده ونتابعه علشان نمنع السكند اوستيوبروتيك فراكشر.
ويمكن اقول لك حاجه كويسه، احنا كان عندنا سيشن مع الايجيبشن اكاديمي اوف بون هيلث مع الانترناشونال اوستيوبروز فاونديشن. احنا السوفت وير بتاعنا سابق الاي اف، يعني الاي اف لحد دلوقتي بتدخل الداتا لسه يعني بنقول عليها بريليمينري فيز، لسه بيجربوا السوفت وير. احنا الحمد لله سابقين والداتا بتخش معانا كويس قوي، والحمد لله يعني we are able to monitor all our patients.
طيب جميل، اخبار حلوه، بركه مجهوداتك يا ياسر. شكرا جزيلا يا حبيبي، شكرا جزيلا.
اسئله ثانيه؟
ازيك يا دكتور ياسر، شرفتنا والله. اهلا بيك يا دكتور ياسر، شرفتنا وسامعين انك جاي بكره ان شاء الله، بس بنحذرك من الدكتور احمد. خد بالك، ناوي على نيه. طيب واحنا كنا بنقول لحضرتك ان بردك حته ان التريتمنت بتاعت الاوستيوبروزس، يا ريت حضرتك تدينا فكره مثلا هل فعلا بيبقى افكتيف بالنسبه للاولد ايج ولا يعني ايه فكرك عنه؟ يعني بلاش خليها كده مفتوحه يعني.
بصي، طبعا زي ما احنا عارفين الايكونومي داخل معانا في القصه دي. احنا مش بس بنعالج طب، احنا بنعالج طب وليفل ايكونوميكال فريم وكوست افكتفنس ماشيه معانا. ففيرست لاين على مستوى العالم كله هم الاورال بيسوسفينيتس. الاورال بيسوسفينيتس طبعا كمان احنا جينيريك اورال بيسوسفينيتس افيلابل. يعني انت في مصر لسه عندك كوزاماكس. انا كوزاماكس موجود عندي في انجلترا خلاص. انا موجود عندي الكترونيك اسيد الكوست بتاعه في الشهر 4 جنيه استرليني مقابل 23 جنيه استرليني للكوزاماكس مثلا. فاحنا نفس الكلام بالنسبه للريزيدورنيت، فاحنا شغالين جينيريك الندورنيت وريزيدور. بس احنا عندنا بقى في متابعه. You have to monitor the patient, you have to do DEXA scan, you have to monitor fractures. Any case of failure or lack of response within 2 years, we move to the next step is denosumab. أي عيان intolerant to oral bisphosphonate for whatever reason, we move to denosumab. فالدينوسيماب حاضر معانا as a first line، يعني first second line. زوليترونيك الحقيقه يعني مش فيفورت قوي، كان في ناس كتيره شغاله فيه اللي هو يعني محتاج العيان يقول لك الكومبلاينس والاديرنس ثيرابي. فلو انت حاسه ان العيان عنده بروبلم والاديرنس ثيرابي بس الحقيقه انا لقيت البيشنت مهم قوي. ولما بتشرحي للعيان بتوري له قدام، انا بوري له قدامي موديلز اوف اوستيوبروزس وبخليهم يدوسوا على بول ويشوفوا بول يعني ايه وات ذا بول versus normal bone. They got convinced when they take a medicine, especially once a week. الستيب بعد كده الباراثيرويد هرمون والروموزوسيماب نازل جديد دلوقتي، هو لسه في مصر هينزل كمان سنه او سنتين. روموزوسيماب نزل عندنا في انجلترا شغال مينلي فور هيب. روموزوسيماب has advantage of being anti-resorptive and bone stimulating factor. هو بيشتغل as bone builder and anti-resorptive في نفس الوقت. وبيشتغل كويس قوي على الهيب، ودي كانت one of the problems if your patient has hip osteoporosis and that denosumab didn't work well. Parathyroid hormone usually works very well for vertebrae. فلو عندك patient at high risk of hip fractures, we prefer to use rosucimab. Rosucimab has its own side effects also, especially cardiovascular problems, so you have to select your patient.
السلام عليكم، ازي حضرتك يا دكتور ياسر؟ حضرتك انا كنت عايزه اسال، هو يعني احنا التريتمنت بتاع الاوستيوبروزس في حالات الاولد يعني خلاص محفوظ ومعروف، لكن اللي بيلاقينا المشكله بتقابلني لما بيجي لي تشيلدرن، لما يجي لي طفل صغير وعنده اوستيوبروزس وبيبقى المشكله بقى انه في بعض الاحيان بيبقى عنده هايبوكالسيميا كمان. فطبعا البيولوجيكس في حالات التريتمنت اوف اوستيوبروزس معظمها ما بيستخدمش في التشيلدرن. كنت عايزه اسال حضرتك ايه الحاجه اللي ممكن نستخدمها، وايه الدوز بتاع الفوزاماكس او غيره يعني في حالات التشيلدرن اوستيوبروزس. في حالات برضو اوستيوجينيسيس امبرفكتا جات لي كتير، وبرضو بنقف جنبها قدامها ونبقى مش عارفين ندي ايه. وشكرا لحضرتك.
بصي هي دي محاضره بحل. نتكلم كده عن الدرجه دي، نخلي المره الجايه نتكلم على مانجمنت وبيجان الاوستيوبروز. الاوستيوبروز بس انا هتكلم بسرعه كده. الاوستيوبروز البيدياتريكس طبعا مختلف تماما from the others. We do not rely on T-scores because T-scores already other healthy female age 25. فاحنا بنعتمد مين على فراكشر هيستوري بتاع العيان. بنعمل دي بس بنعمل سيف سكور ما بنعملش تي سكور، لكن الدايجنوز is based on fractures and the age of the patient. بعد كده بقى بنشوف ده برايمري او سكندري، واذا كان عنده دي جينيتك ولا لا، بس جينيتك امبرفكتا. احنا معظم دول بنديهم اي في ما بيحطوش اور، فبيبقى اي في مونيتورنج برضه احنا على فكره التريتمنت از نوت فور جود، التريتمنت از فور سيرتن تايم افتر ذات ويل ستوب. عندي بيوبرتي دي ليها فاكتور. احنا على فكره we are nearly in the final stage of publishing updated guidelines for managing osteoporosis in pediatrics. فان شاء الله دي انا هتلاقينا بننشرها خلال بدينا مانث اور تو. لكن اوعدك المره الجايه ان شاء الله في اسيوط نعمل محاضره بحالها على مانجمنت وبيدياتريك اوستيوبروسيس.
في حاجه في البيولوجيكس دلوقتي دوكيومنتد في حالات الاوستيوبروسيس في التشيلدرن، يعني في حاجه زي مثلا البوريليا زي كده هتبقى دوكيومنتد في علاج الاوستيوبروسيس في التشيلدرن، ولا ستيل ناو البيولوجيكس مش موجود معانا؟
لا البيولوجيكس لسه مش موجوده بسبب الحاجات اللي هم المشكله في البيدياتريكس ان انت ما فيش خالص اي ستاديز معموله فورمال ستاديز او كومباراتيف، وعشان كده احنا حتى ما فيش تريتمنت جايد لاينز فور بيدياتريك تشيلدرن. Talking about treatment recommendations, not guidelines. البيولوجيكس لسه مش دلوقتي خالص، احنا شغالين كله انتي ريسورتيف ميني دوميترونيت انتي ريترونيت.
شكرا.
شكرا دكتور ياسر for this very interactive session.
هل بالنسبه للتريتمنت
سؤال ثاني؟ اوكي دكتور ياسر في سؤال ثاني
في التريتمنت، هل ممكن اعتمد على الدايت بس ولا لازم ادي معاها كالسيوم سبلمنتس وكده والفيتامين دي من الصن وكده، ولا لازم برضو دراجز وكده؟ بالذات البيدياتريك والاولد، البيدياتريك والاولد في اعتماده على الدايت والصن والدراجز. لازم دراجز ولا ممكن الدايت لو دايت كامل وفيه كالسيوم ممكن ما ياخدش دراجز بالنسبه للكالسيوم؟
احنا بنتكلم about management for osteoporosis.
ايوه
انت what is the aim? The aim of osteoporosis management is to deposit calcium into the bone.
Yes.
اللي كان موجود عندي قبل كده responsible for this role was estrogen for women. فانا دلوقتي ما عنديش estrogen، فانت whatever amount of calcium you're going to take will not go to the bone. احنا عندنا في two factors. نمرة واحد انت your calcium in the blood must be within normal.
Yes.
And your parathyroid gland working on this to maintain the calcium for the muscles, the nerves, all of this relying calcium. So that's fair. If you are deficient in calcium, you withdraw calcium from your bank of calcium which is your bones. طيب انا دلوقتي محتاج حاجتين، محتاج ان انا to maintain the calcium in the blood at the same level, that's number one, and then to have extra calcium to put it into the bones.
Yes.
عشان كده احنا بنقول للادلتس واحنا بندي كالسيوم مانجمنت بندي دبل ديلي ريكوايرمنت. بس كنا بندي كالسيوم بندي 1000 والكالسيوم 800 ملي جرام اوف كالسيوم and 800 units of vitamin D. بندي دبل ديلي ريكوايرمنت so that you maintain your blood calcium and you put the extra into the bones. Regardless في ناس تقول لك ماشي هتاخد يا سيدي هتشرب 3 كوبايات لبن كل يوم وتقعد في الشمس وكل حاجه تمام، ما عنديش مشاكل. Who will put the calcium into the bones? You need something to put the calcium into the bones. فانت محتاج to give management whether bisphosphonates or anti-resorptive. واذا ما اشتغلتش بتدي بون ستيميليتنج فاكتورز
مش كالسيوم على طول يعني عشان نسمع مش عايزين نفوت.
شكرا
بيه. شكرا دكتور ياسر. اشوفك على خير ان شاء الله. شكرا دكتور ياسر. السلام عليكم. Now it is my pleasure to introduce my dearest professor, Dr. Nuran Abaza. She will